of the D.Y. Patil Postgraduate Lecture Series. We are very pleased to have with us Dr. Atul Ambekar. I'll ask Shilpa to do the honors of introducing him to all of you. In the meanwhile, I also welcome Dr. Shilpa Agarkar, who is the moderator for today. Thank you so much to both of you for taking time out from your busy schedules and being with us today. I've known Dr. Shilpa for many years now. Dr. Atul, I've had the opportunity to meet with him occasionally at some conferences and had the pleasure of hearing him on many occasions. So he is known to all of us as well through his prolific oratory skills as well as his work in the field of substance abuse. Dr. Shilpa is an additional professor at the Department of Psychiatry and the Drug De-Addiction Center of Excellence at GS Medical College at KM Hospital for nearly 26 years now. She is a nodal officer and a regional resource for the coordination committee and the DTC scheme for the Ministry of Health and Family Welfare. She has been the ex-president of the Bombay Psychiatric Society from 2019 to 20. She is a member of the Addiction Psychiatry Society of India. She is a member of the National Scientific Committee for Addiction Prevention. She has been an advisor to the PG Psychiatry Education Committee of the West Zone from 24 to 25, and she is a chairperson of the Addiction Medicine Specialty Section IPS from 2024 to 25. She also has yoga as an area of interest to her apart from addiction medicine. I think addiction medicine being an area of interest is quite evident with the prolific amount of work and the volume of work that she has. So thank you so much, Shilpa, to be with us today and to agree to chair this session. I hand over the proceedings to you for now, and I shall come back towards the end of the talk. Over to you, Shilpa.
Thank you. Thank you, Rashmin. It's a pleasure to be moderating this session of D.Y. Patil PG lecture series. Well, the reasons are twofold. One is that the topic that you have chosen this time is really very interesting. I always feel that those who are treating substance use disorders must know the motivational interviewing techniques. And since I read the book by Miller and started using these techniques, I have found it really helpful in engaging these patients as well as treating them and getting them more motivated or enhancing their motivation as well. And I insist that every resident reads this book and starts using this technique. And the other reason, of course, is the speaker. It's a pleasure to moderate this session by Dr. Atul Ambekar. And I think 100 marks to you, Rashmin, for selecting him as a speaker. Because I've heard him on different platforms. We go back many years. I think Dr. Atul had not even joined NDDTC then. Probably he was with NACO or UNODC, I don't remember. And I've attended a training session then, I think a few decades ago. And after that, he joined, of course, NDDTC AIMS. And as they say, the rest is history. Because now he's a professor at NDDTC AIMS. He's also the Secretary General of Addiction Psychiatric Society of India. He's a member board of directors of ISAM. He's a member editorial board of International Journal of Drug Policy. He's an honorary fellow, School of Criminology, Hong Kong University. The resource person or expert for UNODC, UNAIDS, WHO, and INCB. He has been a principal investigator, and we were fortunate to work with him on this National Drug Use Survey, which was published in 2019. He has won the BMJ South Asia Award, Non-Communicable Disease Initiative of the Year 2016, and National Resource Center NCD's Award for Outstanding Contribution in 2022. He has 100+ publications, including peer-reviewed papers, books, manuals, and monographs. And his special interests obviously are drug policy, harm reduction, epidemiology and health system strengthening, which he has been doing for so many years. So it's a pleasure to have you, Dr. Atul, and over to you. I'm sure his session is going to be very, very interesting. And if the residents are attending, I'm sure from tomorrow itself they can start using his messages and work with the substance use disorder patients. Sorry, over to you.
Thank you. Thank you very much, Dr. Shilpa, for this very generous introduction. And thanks a lot, Dr. Ashmin, for giving me this opportunity. It's always a pleasure to discuss, to find people who are interested in the same things as you are professionally. And all the topics in the addiction psychiatry are very close to my heart. This is what I live, breathe, eat every day. So I'm very, very happy to share some ideas, some understanding about the motivation enhancement techniques or motivational interview for substance use disorders with all the participants today. If I can be allowed to share my screen, someone needs to stop sharing their screen so that I can share my own screen. I hope my screen is visible now.
Yes, it is, Dr. Atul.
Yes, and is it visible in the full screen mode?
No. You have to make it full screen, please.
Fine.
Yeah.
Right. So I hope it's now visible in the full screen mode.
Yes.
Great. So, so for all the audience members today, particularly my younger colleagues, all the senior faculty members who are there, all the professionals in the audience, they would find this topic not really very new because they are, I'm sure all of them are familiar with it. I'm sure all of them are practicing it, and many of them actually maybe much more experts in this than I am. But for younger colleagues, I believe the principles which I am going to discuss today, they will find it very useful in not just for increasing the motivation of patients with substance use disorders, but in general as interview techniques for dealing with all kinds of mental health problems. Because as you know, the only good skill we as psychiatrists, mental health professionals are supposed to possess is the skill to talk to people in a manner which helps us understand their problem and so that we can find ways to help them. So for in general also, if you practice motivation interview techniques in the professional kind of interaction with our patients, you will find it very, very useful in your clinical practice. Obviously, as Dr. Shilpa was also telling us, that there are books and volumes written on these interview techniques. So these are this, and there are actually courses on just this, which are 5 days to 1 week to 2 week courses just for this. Obviously, all of this cannot be encapsulated in a small half an hour, 40-minute talk. What I will do is I will just give some of the examples of and some of the basic principles of these interview techniques, which by practice you can hone your skills and then sort of improve them. So as disclaimers and clarifications, this is what I was telling you, that I cannot claim to be really an expert in this area. Whatever little I have read, whatever little I practice with my patients, that's what I am sharing with all of you. So in general, if you know, all of us may have changed at one point or the other something in our behavior, and changing people's behavior is a very, very, very big puzzle piece, not just in behavioral sciences or mental health, but in all other fields such as healthcare in general, getting patients with diabetes to take their medicines, getting patients who are overweight to lose their weight. All of this requires behavioral change. Social services, justice system which deals with habitual offenders. So all of these areas of public life, they require behavioral change, and that remains one of the very difficult tasks in all fields, particularly for substance use disorders. It's supposed to be a challenging because many of our patients, and I will come to it in more details in a short while. This is a very widely prevalent myth that people, those who have substance use disorders, they really do not want to quit. They don't want to change themselves. You will often hear this being told to them by the health professionals as well as by their own family members. Oh, तुम तो ठीक होना ही नहीं चाहते, वरना जो ठीक होना चाहता है वो क्या नहीं कर सकता, जो मन में ठान ले. This is a very common myth. In fact, what we need to realize is unsuccessful desire to stop or reduce the substance use is one of the criteria for substance use disorders. It's one of the very basis on which people have this disorder called as substance use disorder or dependence. If everyone were to stop using substances on their own without any professional help, then of course all of us will be jobless. हमारे घर में चूल्हा सिर्फ इसीलिए जल पाता है because there are people who are unable to change their behaviors and we are there to help them. So one thing which we need to understand is, yes, our patients do want to quit, do want to change their behaviors. There are some various factors which make it difficult for them to do so. These are the many myths about actually motivation. And motivation, particularly in substance use disorders. People believe that motivation is fixed. It's because their people have this kind of personality. Patients have addictive personality, and that's why they can't change. Rationalization, denial, they are seen as characteristics of addiction. Resistance is seen as particular feature of unmotivated patients. And if you need to change this, you need to confront them. You need to sort of engage them in a duel or a fight. This is the kind of misconception people have. With improved understanding in behavioral sciences, we now know that resistance as well as motivation, they largely occur in an interpersonal context. So in other words, if people are resisting for change in an interpersonal context, when you are talking to them in a therapist-client relationship, then in this interpersonal context, it should be possible to change their motivation. Also, what we say is denial. Typically when patients deny that they have any kind of problem. So this denial in addiction treatment is not so much a client problem than a therapist skill issue. If the patient is saying, no, I don't want to quit, I don't want to get better, I'm fine as I am, that means this is possibly not, patient is not telling about themselves, patient are telling about us, the therapist, how they perceive us. Also, all kinds of interactions which are confrontation, which evoke defensiveness and counter arguments in people, that makes it even more difficult for people to change. And hence, if we see them adopting more resistance, then we come to a conclusion that these people are difficult to change. So it becomes a self-fulfilling prophecy. So what we need to understand from these two slides basically is that yes, patients may have difficulty in changing themselves. We as therapists have this job, has this task to help them move forward in this cycle. We now understand that motivation is multidimensional. Motivation is also dynamic and fluid. The same person who today thinks that it's difficult for them to quit taking drugs, tomorrow they may be more amenable. Think about yourself. We ourselves may have thought multiple times to change some of our habits. We might have thought कि कल से जल्दी उठेंगे, I will study regularly, I will do exercise regularly, I will practice some good habits. We are able to do that for some time, but then sometimes on some days we find it very difficult to stick to our plan. Our motivation goes down. So motivation is a fluid phenomena. It's a changeable phenomena, and hence it's our job as therapists to change it in a positive direction. In fact, there is I'm not going to details of this, but there is a self-determination theory which suggests that people inherently want to engage in those activities which meet their needs for autonomy, for their competency, which means their beliefs that yes, they are controllers of their own lives, and their relatedness. And hence, for motivation, there are factors which are responsible for intrinsic motivation, such as desires, needs, values, goals in life. And more importantly, there are many extrinsic factors, social influences, external rewards, consequences. Our job is to help patients, help our patients to work with them to increase both intrinsic motivation as well as to help them see the extrinsic motivation factors for them. Naturally, behavior change is a process that occurs over time. So, in general, this is something no-brainer actually. Behavior change is a process, it is not a single event. So, it occurs over a period of time. So, it's difficult to expect that in just one interaction, you will see a very important change in patients. I particularly tell my younger colleagues, my residents, always this, that whenever you are talking to a patient in the OPD on the first day in the clinic, don't think that your victory will be only when patient says after your interaction that doctor, yes, I have decided I want to quit taking alcohol now. Even if the patient says, fine, I am going now, I will see you again after 3 days. That itself is a big victory. Engaging the patient in treatment till your next follow-up, that itself is a big achievement. So smaller goals, setting smaller goals and helping patients achieve them is very, very important. All of us need to make in our day-to-day life decisions about important life changes, marriage, career, buying a house, and most of us, whenever we take this decision, we really don't go to a therapist or counselor to make such decisions. We may go to some other kind of experts, but we really do not always go to mental health professionals for this. So there are various other ways in which people make these decisions. We need to help our patients in the therapist-client context to talk to them in a manner which helps them take right decisions and then help them achieve those goals for them. I'm sure most of the mid to senior professionals, they are already aware of this trans-theoretical model of change, whereby for all kinds of behaviors, people go through these various stages of change, which begin with pre-contemplation, when they are not even thinking about changing their behavior, contemplation, when they are thinking, they have started thinking, preparations, when in their minds they have started making some mental preparations for changing their behavior, action stage, when they have actually taken some step to change their behaviors, and finally when they stick to their changed behavior, that's the phase of maintenance. Usually people are supposed to move in this particular direction, but this cycle can break at any point in time. People can move backward also, and which is a natural process in substance use disorders. As therapist, our job is to move patient one slot ahead, one rung above in this particular cycle. So even if we see a patient in pre-contemplation, we do not expect them to reach the stage of action on the day one itself. Even if we are able to instill a little bit of doubt in their mind, that itself could be a victory for the first day's interaction. So this model is really helpful in understanding where patients are and where do they need to go. In general, remember this: if you are sitting in a psychiatry OPD or in an addiction clinic OPD and you see a patient walking in, from the door, you can reasonably sure that they are by and large in the preparation or action phase, particularly those patients who have come to us voluntarily. In what are the kind of settings where we can find people with pre-contemplation or contemplation? In the community, which means outside the healthcare setting. Number one there. Number two, in the healthcare settings, when we are encountering these patients in some other context. For example, when you see a patient who is seeking help for their right hypochondriac region pain, which is because of liver disease, which is because of their alcohol problem. So those are the kind of patients who are attending orthopedic ward because they are admitted because of a fracture, and the fracture occurred because they were driving under intoxication. Those are the kind of patients who may still be in pre-contemplation or contemplation for their substance use. Or alternatively, even in addiction clinics, you may find people who are actually in preparation phase or action phase for one substance. For another substance, they don't think that that's a problem for them. Typical example, alcohol and tobacco. Patients who are suffering from alcohol dependence, they may come to us seeking help for their alcohol, but for their own smoking, they might think that that's not a big issue. At this moment, they just want to focus on their alcohol. So those patients can be in really pre-contemplation phase for tobacco, while in a preparation or action phase for their alcohol use disorders. So as therapists, it's important for us to understand where patients are and help them move forward in this cycle. Ambivalence. What do we mean by ambivalence? So basically, most people, even those who we see demonstrating a lot of resistance, those who we typically say that patient is in denial about his alcohol use problems, even those patients, if we talk to them patiently, we will find that there is some degree of ambivalence inside them. So basically, people have explained it in the manner that as if it's like there is a committee in your head, where some people are saying things on one side and some people are on another side. Some people think that it's very difficult to quit alcohol, your life will be hell because of alcohol withdrawals and other issues. Some people think, no, you should quit alcohol because this alcohol is causing you a lot of problems. And these committees are inside your heads, and there are arguments, counter arguments going on from both the sides inside patient's head. We need to help that committee win in patient's head, which thinks that yes, behavior change is required and behavior change is possible. Whenever we encounter such people who are not trained, people who are not well informed, when they are working as therapists or mental health professionals, and they encounter people with ambivalence or dilemma about quitting, those who are in denial or resistance, the first reflex for most of the doctors, those who are not mental health professionals, is doing these kind of things. Immediately they will start educating the patients. Oh, इतना सारा शराब पीते हो तो बहुत बुरी बात है, तुम्हारा लिवर खराब हो जाएगा, तुम तो बर्बाद हो जाओगे. Giving them warning, analyzing them, start advising them, start directing what they should do. These are the kind of quick fixes which most physicians, those who are uninformed, they employ. A very typical example, very typical interaction which happens between a general doctor, not mental health professional, and a patient in India is, cigarette पीते हो छोड़ दो बहुत खराब बात है, दारू पीते हो कम करो या बिल्कुल बंद करो बहुत बुरी बात है ये. So that they say, and they think that this is the all which is required. They have directed the patient, they have educated them, and then that should be helpful. But as we know, for substance use disorders, it's rarely helpful. In fact, it can be much more harmful. Why? Because these are the kind of reactions patients give when reflexly a doctor or therapist treats them in this manner. They either feel not respected, not understood, and hence display a kind of resentment, or they start arguing, defending, and in a way demonstrate their resistance, or they will further disengage, inattentive, become passive, just stop talking to you, they will stop coming to you, retreat. We need to avoid this. We need to actually make sure that patients are willing to come to us on some other day. And for that, even if we end today's meeting on the note, fine, continue with your substance use, but think about what I have said, and let's discuss this in more details when we meet next. That's a winning strategy, rather than saying that मैंने तो बोल दिया है छोड़ दो, आगे करना ही नहीं करना है, आपकी मर्जी है, जाओ. Making people feel bad really helps them change. We need to make them feel good, in fact. So I'm going to show you two pictures here of two people engaging in two different kinds of activities, and both these pictures involve activities which require two people. What's the difference between these two activities? On one hand, there is a duel, a sparring, a wrestling, a kind of fight going on between two people. And on the other hand, there are two people dancing, a kind of ballroom dance. So essentially, for many people, uninformed mental health professionals, they believe that it's a kushti or boxing ka match between patient and the therapist. Whereas the patient doesn't want to change, but therapist जबरदस्ती उसको छुड़वाता है, जबरदस्ती उसका mind change करता है. That's not the principle involved here. Basically, the therapist and the client, they need to move together gently and sway with the motion. So what we need to remember is you don't have to make change happen because you simply can't. You as therapists don't have to come up with all the answers because you probably don't have the best ones. You don't know really what patients are going through. So we need to remember that as a therapist, we are not wrestling with our patients. We are dancing together. We are gently holding their hands, their bodies, their torso, and guiding them to a direction, rhythmically swaying, making them fall in line. So that's why, because as opposed to the kind of interaction which we discussed the 2 slides ago, the usual human response to a more listening, evoking, empathetic style of conversation is that people feel more accepted, understood, respected, and hence they find it more easier to engage and change. So essentially, our motivation enhancement interview techniques that I'm going to talk about, they are actually helpful in number one, making good rapport with the patients, keeping them engaged in treatment, which ultimately would result in them understanding things from your perspective and analyzing them to change their own behavior. This is what the crux of the MI or motivational interviewing is, a particular way of talking with people about change and growth to strengthen their own motivation and commitment. A very old kind of interviewing techniques, uh, very strong evidence base, and I'm not going to bore you with all the review of literature here. Relatively, it's very brief. A typical session may range from just 10 minutes to multiple sessions spanning many minutes to many hours. It can be very easy to manualize, and it is verifiable by your supervisor. Is it being delivered properly or not? It can be generalized across problem areas, though it has been used largely in the context of substance use disorders, but for a wide variety of behavior change, this can be used. It complements other kind of treatment methods, particularly your pharmacotherapy. One of the important areas of our pharmacological treatment is ensuring compliance and adherence. And if we increase patients' motivation to comply with treatment, ergo, they have improved their motivation to change their behavior of drinking as well, or substance use. It can be adopted in any culture, any language, and is being applied in many different fields. The meta-analysis or reviews articles have found small to strong significant effects for substance use behavioral outcomes compared with no treatment, and it's as effective as other counseling approaches, with the advantage being offered of relatively low cost, low resource. So you don't really have to be a PhD in psychology to be able to effectively deliver motivation interview technique. Just any graduate, or in fact a 12th passed individuals. We have trained people with just very basic school education in working as paramedical workers and helping people change their behaviors. What's important is the rather than the qualification of the therapist, more important is the counselor's adherence to the skills. So number one, learn these skills and adopt these skills in your day-to-day work. That's what is much more important. For this, it's important to use open-ended questions, more simple and complex reflective listening, and I will come to it in much more details in the subsequent slides. So, in this particular talk, over next few slides, I am going to discuss some of the motivational interview techniques. And here, for the ease of understanding and explanation, I am going to use quite a lot of acronyms. So first is the acronym which goes by the name of PACE, which is supposed to be the spirit of MI. PACE, PACE, stand for partnership, where we understand that motivational interviewing is done for and with a person, not against a person. It's not a way of tricking people into change, but actually activating their own motivation. A stands for acceptance, where we accept people as they are, treat them with dignity, where we respect their autonomy, respect that they have the choice to continue use or reduce or stop their drug use. And we need to be seen as accepting this choice, this autonomy that they have. C stands for compassion. Compassion is something which must be reflected in our attitude, our interaction with the patients. And E stands for empowerment, where we evoke the attitude of I am not changing you, I am helping you look into yourself, find that reservoir of strength, draw your own on your own strengths and change yourself. So I am actually empowering you to change yourself. So partnership, acceptance, compassion, and empowerment are the basic spirit of MI. That was the spirit, PACE. Now there are 4 fundamental tasks which we need to do in motivational interviewing. The first of these tasks is engaging. Another of this task is focusing, followed by evoking, followed by planning. Right? They look like very abstract words at this moment, but I'm sure when we go into slightly more depth, you will understand, oh, this is very easy and this is something I can do myself. So engaging, focusing, evoking, and planning, we will understand all of them one by one, looking at the engaging tasks. Engaging tasks simply, which means we are doing something which engages our client with us to establish a context of trust, safety. And for this, we need to have very good listening skills, more than talking skills. And for the 4 important interview skills that we use in the engaging task are OARS. Again, another acronym, OARS. OARS stand for open question, affirming, reflecting, summarizing. I will very quickly give some examples of this. Open-ended question. For instance, what brings you here today is typically a open-ended question. Was your family religious? The answer could be only yes or no. So it's a closed-ended question. Tell me about your drinking. What are some good things and some not so good things about it? Example of an open question. If you decided to quit smoking, how would you do it? Another example of an open-ended question. When do you plan to stop drinking? That's a closed-ended question. The answer could be a specific time duration. Similarly, what do you enjoy about heroin? Is an open-ended question. Don't you think it's time to quit? That's a closed-ended question. We doctors, therapists very often commit the mistake of using closed-ended question because we are always wary of time. Because we always are in a hurry. जल्दी से एक patient देखना है ताकि अगले patient को देख पाए. So that's why we believe sometimes mistakenly that closed-ended question will do our job easier and faster. On the contrary, if we use open-ended questions, it's easier to actually keep the patients engaged in treatment and call them another day to take the process forward. In my own clinic, my first very commonly asked question to my patients is, कहिए कैसे आना होगा? Hello, everything okay?
There is some. Can you please mute your mics? Thank you. Mr. Nitesh, can you please mute your mic? Mr. Nitesh, may I request you to please mute your mic? Mr. Nitesh,
If what Nitesh is talking about is more interesting, we can ask him to increase his volume. Right.
Mr.
So,
Nitesh, please request you to mute your mic. Can someone please speak to Nitish?
Right.
Somebody from.
So
Okay, sorry, you can continue.
right. I'll continue. So particularly in my clinic, the very first question I ask to a majority of my patients is, कहिए कैसे आना हुआ? Not even बताइए क्या तकलीफ है, because बताइए क्या तकलीफ है also presupposes that there is some problem. So I start with as open as possible. बताइए कैसे आना हुआ, and then that brings then the next topics for discussion. So in ORS, O stands for open-ended question, and we need to employ these more often. A stands for affirming. What do we mean by affirming here? Basically, to affirm basically means notice what is good or strong points in your client, rather than seeing only pathology, deficits, problems. Let's appreciate what is positive in what they are doing, intending, trying. For instance, patients very often say, मैं कहाँ छोड़ पाऊंगा, मुझे तो सब लोग यही कहते हैं कि तेरे से नहीं छूटने वाली है. बट आप यहाँ तक आ तो गए हैं बात करने के लिए, आप मेरे से बात करने आए हैं तो अच्छी बात है. So that itself is a kind of positive step they have taken, and we need to affirm whatever good they may have done today or they may have done in the recent past. So for this, as they say, we need to put our strength glasses. And this affirmation can also be of different varieties. It may be simple affirmation. That sounds like a good idea. Thank you for coming early today. All these are simple affirmation. Or it may be simple. It may be some kind of complex affirmations, which are comments, positive comments on something enduring about the person, which is more of their characteristics. That takes real courage. You care very much for your family. And this, I'm sure, in your patients with alcohol dependence, you will find this very common description even by their family members. डॉक्टर साहब अगर ये शराब पीना छोड़ दे ना तो ये बहुत अच्छा इंसान है. He's a very good father, very good husband, very good son. Only because of his drinking he has these problems. So we need to find these kind of positive attributes in people and affirm them, appreciate them. R in ORS stands for reflecting, which is basically statements rather than question. Make an understanding, make an andaza of the patient's meaning rather than asking them, which yields more information and better understanding. So basically, whatever they are asked, a question, we can turn it into a reflection. So rather than asking, "Are you angry with your mother?" just say, you seem to be angry with your mother. Don't you see anything wrong with what you did? It's a question. In reflection, the same thing can be said as, oh, you don't see anything wrong with what you did. If you say it in this tone, patient will understand perhaps what you are trying to say and explain it to you better. Are you feeling anxious? Oh, you are feeling kind of anxious. Is reflection. So reflection basically is telling the patients what I understood about what you are telling me. This again may be simpler or complex reflection, just like affirmation. Simple reflection may be simply rephrasing. Patient saying, I am feeling depressed. Therapist simply repeating it. Oh, you are feeling depressed. Complex reflection, which can add some meaning or emphasis and something which can be sort of reading between the lines. That kind of thing is reflected in complex reflection. Patient saying, I am feeling depressed. Therapist may respond like, something has happened since we last met. क्या बात हो गई है ना, so या कुछ हुआ है जिसकी वजह से आप दुखी हैं. Your mood has been up and down in past few weeks. That's again a kind of complex reflection. Another example of reflection or double-sided reflection. A patient saying, I know smoking is bad for my health and my children hate it when I smoke, but it's one of the only real pleasures I have left. I don't know how I would ever relax without my cigarettes. Therapist has listened to this, and now therapist is reflecting. Okay, you wonder how you would get along without smoking. At the same time, you can see how it hurts both you and your family. So this is a double-sided reflection where we have acknowledged both the positive or negative side of it. or the easy and difficult side of the situation that patient has described. So after a reflection, S in ORS stands for summarizing. So which is essentially reflections which will pull together several things which a person has told you. It matters what you chose to include in summary and allow patients to hear various aspects of their experience simultaneously. So, for instance, a typical example I have written here. You say you don't drink that much, but you are drinking enough at night that you experience discomfort in the morning. The way you are feeling bad in the morning sounds a lot like alcohol withdrawal. The reason you drink is to help you forget about the stresses in your life. Your wife thinks you have a problem and doesn't want the children to be with you. You are also embarrassed about your drinking problem. So, in whatever last 10 minutes patient has told us in the history, we can just summarize it and tell it back to patient and get some of this helps actually patient understand that you, the doctor, have understood the patient correctly. And at the end of your summarizing, you can in fact ask the patients, have I missed something? Do you want to add something to it? So that itself puts a very nice succinct summary of the entire conversation. And all these ORS techniques that we talked about, they were important for the engaging task. So after we have engaged patients, the next task is focusing. Focusing task basically is finding a particular area where we want to go, to develop clear mutual goals for the helping relationship. So engaging was about let's take a walk together. Focusing is about finding where we are going. It establishes the direction for the movement, for the walk, for the journey together. Here we must remember the MI is directional but not directive, which means we are not ordering our patients to do something. And the source of this focus can be anything. Source of the focus can be patient themselves. Source can be a particular context in which substance use is occurring or some problems because of substance use are occurring. For instance, drinking and driving, drinking at workplace. Those could be the focus where we change the context. Or the source of focus can also come from clinician. Come to me, keep the follow-up regular. That could be one of the focus. So how do we find this focus? Number one is we need to listen very well. It's important to develop a list of concerns and then moving from more general to more specific areas in whatever patient has told us. Here, it's also important to sometimes identify the urgent issues, even though they may look slightly more complex or difficult. For example, alcohol use disorder. A patient with alcohol problems can have various concerns because of their alcohol use. It may be just heavy alcohol intake itself. It may be the mood problems they have. It may be the biological or physical complications such as blood pressure or neuropathy. It may be the craving which they suffer from. It may be the peer refusal skills because they are unable to withstand the peer pressure. So all of these could be areas where work is required, and we can pick up depending upon the urgency, the complexity, one of these focus first before moving to other areas. Always remembering that one particular of this area may be related to other areas as well. So after engaging and focusing, we come to what is known as evoking. Evoking simply means something helping to rise from within. Why would you want to go there? So how did we start? Let's take a walk together. Where are we going? Why do you want to go there? Once we have found the focus, then this is a natural kind of issue to address. Finding that inside the person, which helps them understand why do they really need to change. This is essentially about strengthen the person's own motivations for change. Here we need to remember the ambivalence, the internal committees in the patient's head. Some members saying this, some members saying that, and we need to help those members which help them change for good. Here, the client needs to find the reasons for change. क्यों बदलना चाहते हैं आप? In fact, in doing these, okay, I'll come to this later when we talk feedback. There are then two kinds of conversational styles or two kinds of interview techniques. which go by the common name of change versus sustained talk. If you look the type of statements here on the left side, desire, ability, reason, need, commitment, activation, taking step, they again form a particular kind of abbreviation. We call them darn cat. D stands for desire. So example of change talk in desire would be, I want to cut down on my drinking. So if the patient says, मुझे शराब कम करना चाहिए, that's a example of change talk. But if they, I love how cocaine makes me feel, or I love how drinking makes me feel, that becomes an example of sustained talk. They don't want to change. Ability, if they looking at what patient is saying, I could cut back to drink with dinner on weekends. तो मैं रोज नहीं पीऊंगा, खाली सैटरडे संडे पीऊंगा, कोई पार्टी होगी तो पीऊंगा, मैं रोज नहीं पीऊंगा, ऐसा भी चल जाएगा. That reflects patient's ability. An example of change talk. Sustained talk, on the other hand, is I can manage my life just fine without giving up the drug. Similarly, reason, examples are written here. I'll miss less time at work if I cut down. Getting high helps me feel energized is an example of sustained talk. Need, I have to cut down. My doctor told me that the amount I'm drinking puts my health at risk. Here, patient is expressing a need because of which they need to change. I need to get high to keep me going every day. This is an example of sustained talk. So what we need to do here is, in these examples of darn cat, we need to identify patient statements and help to evoke from within patients the statements, the thoughts, the ideas which are more towards the change rather than sustenance of that unhealthy behavior. This is also a kind of concept in motivational interview. Very often in pre-contemplation or contemplation phases, you will need to engage people in more of the what is known as preparatory change talk. And once they have achieved this, where they have reached the stage of preparation, then you need to employ what is known as mobilizing change talk for helping them reach the stage of action. So we need to identify what patients are saying, we need to analyze it and evoke from within them more of change talk rather than sustained talk. This is what I was talking about, the desire to change, where preparatory changes like I want, I like, I wish, they express desire. I can, I could, I can't, they express ability. Reason, then if I do this, then this will happen, is the example of reason. Need to change, I need to, I have to, I got to. This expresses the need to change. In the mobilizing change talk is about CAT, commitment, which is reflected by statements which refer to intention, decision, or promise. Activation, I am willing, I am ready, I am preparing, or actually taking steps. So in the change, we need to, as therapists, we need to help our patients come up with the change talk, which may be preparatory as DARM, or which may be mobilizing as CAT. In this particular phase, ambivalence is expected. I wish I could quit, but I really enjoy smoking. I know that quitting smoking would be good for me, but I really don't want to. Anyhow, I have tried before and it's really hard. So basically, this kind of ambivalence is expected. We need to evoke more of the change talk. The internal committee, I will again come back to that example. We can literally talk ourselves into or out of doing something. We need to invite the pro-change members of the internal committee to speak. And for this, we again need to go back and use the engaging techniques of ORS to move in that particular direction. For this, how can we do this? We can ask open questions to invite change talk and then listen with interest. For example, what change do you want to make? This kind of question, which is an open-ended question, will give us the response which is in the area of desire of preparatory talk. ability. Given what you know about yourself, how might you go about in order to succeed? Reason. What are some of the good reasons for quitting smoking or reducing alcohol use? Need. On a scale from 0 to 10, how important it is for you to change yourself? Why that number? Why not 0? Why not 10? Try to understand their need. Finally, the mobilization in the form of what do you intend to do? आप इसके लिए क्या क्या कर सकते हैं? Activation, taking steps. What have you already started? अभी तक आप क्या क्या कर चुके हैं? So these are the kind of questions once you have engaged patients, which will help them actually change their behavior. Some experts also recommend using a kind of confidence ruler. On a scale from 0 to 10, how confident are you that you can do this? Why this number instead of 0? Why this number instead of 10? This will help them change and evoke their own self-efficacy about changing. Another problem which we face in this particular phase is handling resistance, because resistance is mostly about sustained talk. मेरे से तो नहीं होगा, मैं तो नहीं कर सकता, मेरे बस की नहीं है, मुझे जरूरत ही नहीं है, इतनी थोड़ी पीता हूं मैं. So these are the kind of statements which reflect the resistance which we very commonly see in many of our patients. For which we can have the discord, which is observable interpersonal behavior between a therapist and client. Also, you can have this kind of discord. These are interpersonal behaviors, highly responsive to counselor style. So whenever you are encountering resistance, try not to confront there and then. In fact, this particular phenomena of how do people deal with resistance has been subjected to a very good controlled trial in experimental design, enhancing motivation for change in problem drinking. So they actually compared two kind of therapy style, and I'm not going into details, but look at the last sentence. More the therapist confronted, more the client drank. So whenever you encounter resistance, confrontation is a bad idea. What do we do with resistance? We simply roll with it. कैसे कर सकते हैं अब इसको? One way of doing it is, I really don't need to quit drinking. पेशेंट ने जैसे एक स्टेटमेंट दे दिया, मुझे कोई जरूरत ही नहीं, मैं इतनी पीता ही नहीं हूँ. ठीक है, we can have a complex reflection like, ठीक है, that doesn't seem important to you. आपको ज्यादा मुसीबत नहीं लग रही है. Amplified reflection. Example, मुझे कोई दारू की प्रॉब्लम नहीं है, तो उसके लिए हम क्या कर सकते हैं? What is in Hindi or Marathi, what is known as अतिशयोक्ति. We can use the अतिशयोक्ति अलंकार example here. Drinking has never caused you any trouble. तो आप मुझे ये बताने की कोशिश कर रहे हो कि शराब पीने की वजह से आपको आज तक कोई प्रॉब्लम नहीं हुई है आपकी लाइफ में. तो नेचुरली जब हम इतना इतना एक्सट्रीम पे जाके बोलेंगे, पेशेंट्स विल टेल, नहीं नहीं डॉक्टर साहब, ऐसा थोड़ी है, प्रॉब्लम तो हुई है. एंड दैट गिव्स अस अ लिटिल ओपनिंग इन द डोर from where we can take the conversation forward. It can even be a double-sided reflection. For example, patient saying, I don't want to have another heart attack, पर इतनी एक्सरसाइज करूंगा, मेरे से हो नहीं पाएगी, बिजी हूं मैं, फलाना ढिमकाना. It's hard to imagine how you could add any exercise to your schedule, even though you know it would improve your health and help prevent another heart attack. So this is simply reflection rather than rather than directly confronting our patients. Here we can emphasize choices also, for which we need to choose our words tone very carefully. We need to apologize if it looks like there is a discord happening. आप मेरी बात सुन ही नहीं रहे हो, अच्छा अच्छा ठीक, कोई बात नहीं, फिर से शुरू करते हैं, शुरू से बताओ मुझे. This could be one of the way to avoiding resistance or discord. Shifting the focus, reframe a hot topic. आप क्या मुझे शराबी बोल रहे हो? इस सेंटेंस को हटा देते हैं, ये वर्ड ही हटा देते हैं, कुछ और बात करते हैं. Another way of doing this. Coming alongside. Here we connect with reluctance without endorsing it yourself. Right? A typical conversation style which you also employ in your day-to-day debates. चल एक मिनट के लिए मान ली तेरी बात, है ना? We often argue in this manner. But so this could be one of the ways of coming alongside. So we have discussed engaging, focusing and evoking tasks, and then come to, after we have done all this, Then we come to planning task. How will you get there? So how did we start? Let's take a walk together. Where do you want to go? Why do you need to go there? And how will you go there? Planning is about कैसे जाएंगे, कैसे करेंगे change. To arrive at agreeable goals and plans for change, as needed, we need to keep consulting, and to encourage persistence and progress is what we do in this plan. Here, simply we need to identify a change goal, a change plan, confirm it, eliciting their ideas on how they will achieve it, offer them menu of options, and then sort of help them achieve it. I described these four phases, these four tasks: engaging, focusing, evoking, and planning in quite of in a phasic manner. That doesn't mean that there are definite kind of phases. अब engagement खत्म हुआ, focus शुरू करते हैं. It's never like that. Usually, when you begin conversation, you are more focused, or you are more giving more importance to engaging the person, then finding focus, then evoking, and then after you have done all this, you are ready for planning. So usually you proceed in this manner, but there can be a mix and match also. So there can be a kind of recursive relationship between them also. So I have, for now, I have discussed just some of the interview techniques for motivation enhancement. I will very quickly discuss. I will not take much time for the four strategies which we use for motivation enhancement, which you, the residents, the beginners, can use very easily in your day-to-day practice of addiction psychiatry. Feedback, decision balancing, developing discrepancy, and supporting self-efficacy is what we are going to talk about. Feedback simply means acting like a mirror, where we as therapists, we act like a mirror and tell patients about the problems or consequences they have faced in their life because of substance use. शराब पीने से लीवर खराब हो सकता है, एक्सीडेंट हो सकता है. This is not feedback. शराब पीने से एक बार आपको उल्टी लग गई थी, शराब की वजह से आपकी भूख कम हो गई है, that is feedback. In many departments, when people take history of patients with substance use, they make a list of complications because of substance use, physical health, mental health, social, occupational, financial complications. That list is very helpful in our history taking, because that helps in giving the list of consequences patient has experienced as feedback. So simply do the interview of the patient. At the end of the patient, summarize whatever you have learned in the manner. अच्छा, तो शराब की वजह से आपका पेट भी खराब हो गया है, आपका वजन कम हो गया है, आप काम ढंग से नहीं कर पा रहे, पैसा बहुत खर्चा हो रहा है, वाइफ के साथ झगड़ा होता रहता है, और कुछ. So this gives patients an idea. Oh my God, this is causing a lot of consequences to me, and I must do something about this. So these are the kind of examples from patient's life of negative consequences of substance use, which we can use as feedback. If you are using, we don't do it routinely, but if we are using some kind of screening test, such as WHO audit or assist, that scores can be very good feedback technique. So this was one of the motivation enhancement technique of feedback. Then we come to another technique of decision balancing. Decision balancing simply means that we are helping them to weigh, to compare, तौलने के लिए, तुलना करने के लिए, the benefits of change versus vis-a-vis benefits of staying the same, and the cost of staying the same versus cost of change. अगर शराब पीना छोड़ देते हैं तो उससे क्या क्या प्रॉब्लम आएगा आपको शराब छोड़ने से? Withdrawal, craving, these are the real problems. Difficult to socialize with friends who drink. That's a problem of quitting alcohol. But उससे क्या क्या फायदे होंगे? Similarly, अगर नहीं छोड़ते तो क्या क्या आपको फायदे अभी हो रहे हैं शराब करते कंटिन्यू करने से, और आगे क्या क्या नुकसान हो सकते हैं? This is how you help the patients compare the pros and cons of change versus cost of staying the same, cost of change and benefits of staying the same. That, if you do it very well with the patients in a systematic manner, will help actually patients on how to, on why they should change. For some of my patients, I actually employ a paper and pen approach. I sit with them using a sheet of paper and pen and make a list of क्या फायदा है, क्या नुकसान है, क्या तकलीफ है, क्या फायदा है for of both continued substance use versus quitting. Feedback, giving complication list to patients, decision balancing, comparing the cost and consequences, then developing discrepancy. What does this mean? Sounds difficult, but basically it's a very simple thing. Developing discrepancy is enabling them to compare their life, their quality of life, with either other non-users, which may be their friends, peers, and or help them to understand where they are, where they want it to be. This can be a comparison of current status. This can be a comparison of patient's own past and patient's own future. This can also be an imaginary comparison of patients today and patients' imaginary future. आपने कहां से शुरू किया था, अब आप कहां हैं? अगर दारू नहीं पी रहे होते, नशा नहीं कर रहे होते, तो आज आप कहां होते? सिमिलरली, अभी आप दारू पी रहे हैं, अगर आप दारू छोड़ दो तो 5 साल बाद आपके लाइफ में क्या चेंज देखने को मिलेगा, वर्सेस यू कंटिन्यू ड्रिंकिंग एंड सी वेयर यू विल बी 5 years डाउन द लाइन. That's a very interesting way of developing discrepancy. So for instance, I very commonly use the technique of asking the patients to do a calculation of how much money they spend on their substance use per month. I calculate it for a year, and then I estimate or whatever duration they have been using drug, and multiply that number, and that usually comes out like a huge amount. So in other words, I tell them, if you stop it now, in 10 years you will amass this much of bank balance. Feedback, decision balancing, developing discrepancy, and finally fourth strategy or technique is supporting their self-efficacy. After all this, even if the conclusion is that yes, I should quit, but the problem is I cannot, मेरे बस का है ही नहीं, मेरे लिए बहुत difficult है. If that's the problem patients have, we need to simply instill that kind of confidence and hope in them. And by two simple basic statements. The goal is achievable and you can do it. नशा छोड़ना possible है और नशा आप खुद भी छोड़ सकते हो. And for this, we can cite examples of others who have done this. Those may be celebrities. Those may be people patient knows. Even if patient doesn't know anyone, doesn't have role models, we can give role models from our own clinic, our own hospital. हमने हजारों सैकड़ों पेशेंट्स को देखा है आपके जैसे, आपसे भी बुरी हालत में, जब उन्होंने छोड़ दिया तो आप क्यों नहीं कर सकते? So this kind of examples we have to give them and support their self-efficacy. Finally, who should do this? Is it the job of a psychiatrist or a doctor? Or does it require you to be a PhD in clinical psychology? Or any counselor, any social worker? As I was saying, whoever is in the task of interacting with patients with substance use problems, that person may be a nursing staff, a counselor, a doctor, a paramedical worker, they should be able to perform some degree of motivational interviewing techniques in their interaction with the patients. As us as doctors, particularly resident doctors, budding psychiatrists, we must employ these techniques to interact with our patients of substance use disorders. And once we start doing this, we actually find it's a very fun area working in addiction psychiatry. Personally, I find it much more rewarding when I find a patient who is initially reluctant, but later agrees to at least see me till the next visit. I'm not saying that our success should be measured by 100% abstinence. We should, even if patients agree to come to see us again later in the next follow, that's a big victory for us. I'm leaving you with some of the examples of resources, references, which you can go through for more detailed reading. For those interested in videos, there are some very good MI demonstration videos, though not in the context of substance use disorders, but still good examples of interview techniques or interaction styles. Thank you very much, ladies and gentlemen, for your patient list. I know I have taken slightly longer time, but I hope you found it useful. Thank you.
Thank you, Dr. Atul. That was really wonderful, taking us from aptly named spirit of MI, that is space, to, of course, EFEP, engaging, focusing, evoking, and planning, and how to do it. with so many acronyms, so easy to remember for residents, ORS and DAN CAT. So I think if they just keep these few things in mind, I'm sure MI practice won't be so difficult. Thanks a lot for your time and your simple examples and making this big topic, which is called motivational interviewing and enhancement therapy, on which there are books and courses, making it so simple in about 45 minutes. Thank you so much. If there are questions, we can take them now.
We'll request everybody to post their questions in the chat box.
Yeah, if I don't see any questions in the
There is
chat.
one. There is one, maybe.
Okay. Okay. Are these books in Hindi or Marathi that we can suggest to patients for helping them quit?
I mean, there may be such books, and they certainly are. If you do Google search, you can find books which you are suitable for your own cultural context. Personally, I do not actually recommend a lot of books to my patients in my practice. My belief is that if books were able to help you, then what's the job of us? Then what? Why we are here for, right? So books may be helpful in understanding, getting some facts, right? But as professional therapists, if you need us, please come to us. We will help you. I might for giving them information. Lately, I have started searching for some YouTube videos and asking patients to see those videos. But then again, it's fraught with danger, because YouTube kind of algorithms are such that patients start looking for videos on how to quit drinking, and YouTube takes them to advertisements of alcohol brands. So it's best that this is not done by do it yourself mode.
Yeah, I agree. There's another question, Dr. Atul. How to adapt MI for adolescents?
Yes, very good question actually here. So most of the principles of interview style that I referred to, they actually apply to adults, because autonomy, kind of empathy, self-efficacy, uh, these principles are apply very differently when there is so much of age gap between patients and us. Particularly in case of adolescents, it can be tricky, because number one, because of their age, and given our own societal values, they are expected to be more attuned to following the instructions, right, rather than doing what they like or doing what they think is right. So even for adolescents, showing some degree of empathy, as well as respecting some degree of their autonomy, it goes a long way. बाकी सब तो उनको बच्चा समझ के डांट डपट करना और तूने दुनिया देखी नहीं है, हमने देखी है, इस मैसेज में लगे रहते हैं. Just give them little bit of respect and listen to them. That goes a long way. Even though, and I'm saying this fully understanding that very often some of the adolescents themselves be expecting a more of a directive kind of help from you. आप ही बताइए ना मैं क्या करूं. So right. So to address this, I usually do not come with a very clear kind of direction at one go. I initially ask them to mind map kind of thing, make a list of possible scenarios, possible reasons, possible ways in which they can handle a problem, and then help them pick up what is best for them. Thank you.
Thank you, Dr. Atul. I think it's very important that adolescents get respect, and when you talk to them about their favorite things or sports or whatever that they like, music, I think they open up. And if you talk to them separately without the adults accompanying, I think it's possible. And they're also good at identifying triggers if you ask them to. As adults may be defensive, but I have experienced that they say it very nicely, that when we win a match, this happens, or when I feel down about some results, this happens. So I think that identifying and making trigger list also helps with the adolescents.
Thank you.
Any other questions?
I think somebody wants to know about the recording. The recording will be live on the website in another day or two. And all
Okay.
the lectures, past and present, as well as for the foreseeable future, are all available on the website for perpetuity. You can download the slides, you can see the lectures at your convenience anytime at all.
There's one more question that has popped up. Dr. Nitisha asks, am I for SUD with personality issues, especially ASPD traits?
Yeah, yeah. I can understand that when we say personality issues, we actually are more often referring to therapist discomfort rather than characterizing a particular type of patients. Na? Particularly when we talk of borderline, emotionally unstable, antisocial, or in general what are known as cluster B traits. So उनके साथ कैसा बात करना, वो उसमें उसमें प्रॉब्लम हम अपने स्किल की बात कर रहे हैं ना कि पेशेंट्स के साथ मैं जो मुश्किल होता है उनसे बात करने में. So even of patients of this kind, you can engage them in motivation interviewing kind of style. If we remember the basic principles of engaging with different kind of people, setting of professional boundaries, as well as respecting their autonomy, displaying empathy. If you apply these techniques, it should be possible to engage even with them. Uh, Even though it may be difficult for some patients, but it should be possible. Again, as I was saying, rather than we are not really talking of or expecting 100% good outcome in all patients. Motivation interviewing doesn't mean after just one interaction all your patients should come out perfectly clean and decided that they are never going to touch the substances again. Even if they are willing to see you again after 4 days, after next week, that is a good enough. Even if they said, ठीक है डॉक्टर साहब, आपने जो बोला है मैं इस बारे में सोचूंगा, that itself is a big victory. तो पहले तो सोच भी नहीं रहे थे if they were in pre contemplation. So it's really not मतलब if we keep our expectations tailored according to that, it need not be an impossible task. Thank you.
Thank you. The similar lines, another question is, if patient continues to maintain resistance in spite of MI, how to proceed? Any other therapy that helps such clients? So I think you've answered that.
Yeah, yes. And also as I said in presentation, also resistance is very often a therapist issue rather than a client issue. So if you continue to find resistance, it may actually be that there is something which has transpired between these two individuals, which is not in the best interest of the interaction to move forward. And if that is your genuine assessment, not a bad idea to look for alternatives. Look for someone else who can perhaps better help this patient. I mean, we should have the humility to accept that it's not humanly possible for us to be able to help each and every individual on this planet.
Thank you. Is there any set of clients in whom MI is not advisable?
Come to think of it, I can't really think of any. I haven't come across any such guideline which says कि MI करना ही नहीं रहे इसमें. तो ऐसा I really am loss of at words here. There may be people who may be in such great resistance that you require better skills, you require some different approaches or tactics. But I really don't see any label which can be put on a particular demographic कि इसको तो MI नहीं कर सकते. So I don't know the answer. Sorry.
Thank you. And MI for relatives with tobacco dependence. How to deal with pre-contemplation, contemplation? I didn't really get the question, but this is what it says.
I think the question the gentleman or lady is referring to a situation where index patient is different, is being treated for something else, and we find that one of their family members is also happens to chew tobacco. So again, as I was saying, if patients are coming to you in the role of a patient, and you are the doctor there, then half the battle is won already there. Most difficult is to encounter people who are not in the patient therapist relationship, and you have to change their motivation. But employing these kind of techniques, it is possible. We have actually used community health worker type of people, ashas also, to use some of the motivation and enhancement techniques to just deal with the people living in the community with alcohol problems, to help them just come to hospital once and talk to the doctor. So it should be possible to use
Okay.
these techniques even for those people.
For relatives who also have probably tobacco use or any other substance use,
Yes. This can be
and
done. This can be done.
they are in a pre-contemplation. So I think we also do that. Their social workers or counselors help them also motivate them so that they also start
Right.
contemplating.
Right.
Thank you. I think there are no more questions, so I think I'll hand over to Rashmin. Thank you, Dr. Atul. Wonderful session, and it was a pleasure moderating it. Thank you.
Lovely. Thank you. Thank you very much. And thank you so much, Dr. Atul, for taking the time out and to this is a topic which is amongst the most important ones, but unfortunately never being paid enough attention to. Sometimes we get lost in the biological quagmire of all the receptors and circuits and mechanisms in the brain, and some simple communication facts, some simple methods and mechanisms of how we operate are lost in the quagmire. So we are grateful for you to bring this to our notice. And the beauty is how you made it so simple and lucid to understand. Albert Einstein very famously said everything should be made as simple as possible, but not simpler. So, as complex a topic as this, how you manage to simplify it and make it so easy for us to comprehend, to understand, even to a slightly old foggy like me, is truly amazing. So, thank you so much, Dr. Atul, for being with us today and helping us understand this complex topic in such a lucid manner. And thank you, Dr. Shilpa, for making the time and being with us today, and also adding your own perspective to this interesting interaction. And of course, thank you to all the participants who were with us in large numbers, everybody from young consultants to senior faculty, as well as the postgraduate students who are the intended target. But we've come to learn that when we have good speakers, then age and experience is no barrier whatsoever. So thank you all for being with us, and thank you Sun Pharma for their unflinching support. We promise to try and give you more and more interesting topics in the future, and to do justice to you taking the time out and being with us. So thank you all once again, and I wish you a great evening ahead. And finally, again, thank you, Dr. Atul, and thank you, Dr. Shilpa. Have a good evening ahead.
Bye.
Thank you, sir. It was a pleasure.
Thank you.
Thank you. Bye.